Welcome to the Tary Podcast, Season 1, Episode 6. This episode is titled Home Healthcare Medical Standards, an Overview, and it's brought to you by the Tary Quality Team. Tary, as you know, is a medical health tech company really dedicated to quality.
And today we're diving into the core principles, the things that really underpin quality in home healthcare. We're basing our discussion on a comprehensive overview prepared by the Tary Quality Team.
Exactly. We've got two primary documents here, both from the Tary Quality Team, dated April 12, 2025. There's a presentation, Home Healthcare Medical Standards, an overview, and also a more detailed written document providing extra detail on these standards.
Right. And our mission today really is to unpack these resources for you. We want to provide a clear, insightful understanding of the medical standards that guide home healthcare.
Yeah, we'll explore what they are, why they matter, and touch upon the key areas they cover. Always thinking about, what contributes to a safe and effective home healthcare experience.
That's the goal, safety and effectiveness.
And for anyone listening who wants to dig even deeper, there's a link to the source document right there in the description. You can also find out more about Tary and our commitment to quality at tary.care. So let's get started. What exactly do we mean by a standard when we talk about home health care?
Good place to start. A standard, in this context, it's essentially a document. It offers requirements, specifications, guidelines, or characteristics to make sure services are, fit for their purpose.
Okay, so it's like a benchmark for quality.
Exactly, a benchmark. And these standards, particularly things like JCI standards, Joint Commission International, they set specific performance expectations. They outline the structures or functions that are really crucial for, say, hospital accreditation. They're not just suggestions.
Right, they're requirements checked during surveys.
Precisely. And the documents also talk about the intents behind these standards.
Intents. What does that add?
The intent explains the why. Why does this standard exist? What's the reasoning? It provides the parameters, the goals. It helps you see the bigger picture, not just the rule itself.
So it's the purpose behind the rule. Makes sense.
And often includes best practices, the absolute must-haves.
Okay, and then there are measurable elements, MEs. How do they fit in?
The EMEs. These are the specifics. They're what gets reviewed and scored during those on-site surveys. They show how an organization demonstrates compliance with the standard.
So that's the proof, the evidence.
Exactly. They make the standard concrete, showing how the intent is being met in practice.
Got it. And this whole standards manual, it serves multiple purposes, right? Not just for the surveyor.
Oh, absolutely. It's a guide for management, for one thing, helps run the program effectively. It's also a roadmap for improving service quality, for delivering better patient care.
And it clarifies compliance, makes sure everyone's on the same page.
Yes, and even helps with the language used, the terminology, creates a shared understanding, a framework for excellence.
Okay, a guide, a quality tool, and a communication aid. Let's pivot slightly. Our sources mention CBAHI.
CBAHI, the Central Board for Accreditation of Healthcare Institutions.
Right. What are their specific intents for home healthcare services? What groundwork do they lay?
Well, CBAHI lays out several key intents. A fundamental one is ensuring qualified individuals provide the care.
That seems paramount. Competent professionals.
Absolutely. You need skilled people directing and delivering the services, especially in someone's home.
Makes sense. What else does CBHI emphasize?
They focus heavily on having clear admission and discharge criteria.
So knowing when someone starts needing care and when it's appropriate to stop.
Exactly. It ensures services are used appropriately. Plus, they stress the need for established policies and procedures for the actual care delivery. Things like care plans, handling lab work, medication management.
Day-to-day operations need clear guidelines.
Definitely. Policies for initiating, implementing, reviewing care plans, making sure they adapt as patient needs change.
Dynamic plans, not static ones.
Right. And coordinating all the different services, physical therapy, nursing, aides, so it's a smooth experience.
Integration is key. What about specific things like labs or meds?
Yep. Specific intents cover ordering and handling lab tests correctly in the home setting. Same for medication management, ensuring safe and effective use at home.
And patient education. That seems huge in home care.
Oh, it's a major focus. Patient and family education is critical for their involvement and for safe care delivery. Then there's infection control, always vital.
Minimizing risks for everyone.
And overarching all of this is, the core intent, promoting patient safety and overall quality and every aspect.
Safety and quality above all.
And one last point from CBAHI, standardized and effective transfer processes if a patient needs to move to another healthcare organization. Seamless transitions.
Okay, a really thorough framework.
Yeah.
Now let's really zero in on the patient experience. Patient-centered standards.
Yes, this is the heart of it. And a big part of that is the patient safety goals, the PSGs.
PSGs, what are the key goals here?
Foundational stuff. Improving patient identification is number one.
How so?
Using at least 2 identifiers, name, date of birth, that sort of thing, whenever providing care or treatment.
Simple but crucial.
Absolutely. And labeling specimens right there with the patient present.
Avoids mix-ups. What's another key goal?
Enhancing communication among caregivers, especially verbal orders. There needs to be a process. Write it down, read it back, get confirmation, reduces misunderstandings.
Read back is key. Important stuff. What else?
Medication safety is another big one. Ensuring meds are used correctly and safely.
Always a high-risk area.
And reducing healthcare-associated infections. Big emphasis on hand hygiene guidelines and effective programs.
Hand washing. Seems basic, but so important, especially at home.
Critically important. Then there's minimizing harm from falls.
Falls are a huge concern in home care, aren't they?
Definitely. So the goal involves assessing fall risk initially and ongoing putting interventions in place for those at risk and monitoring how well they're working.
Proactive assessment and action.
And finally, identifying safety risks specific to the patient population being served.
Like what?
The source mentions risks linked to home oxygen therapy, for instance. Recognizing those specific risks and mitigating them.
Got it. So being aware of the unique dangers for the patients you serve. Okay, beyond PSGs, the materials talk about patient access and assessment PAA. Let's break that down. First, access.
Access starts with ensuring patients get services based on their actual health needs and eligibility. It involves a discussion, considering resources and guidelines, and there needs to be a written policy for acceptance into care.
A clear process for who gets in, based on need and the service's ability to help.
Exactly, and consistently following that process. If someone can't be accepted, the referrer needs to be notified.
Transparency. What about barriers to access? Physical or language barriers?
The standards emphasize actively reducing those barriers. Physical, language, cultural, whatever makes it hard for patients. Leaders and staff need to know the common obstacles and have ways to address them.
So problem solving to make care reachable.
And managing waiting lists, if they exist. Informing patients about other options if there's a delay.
Keeping people informed. Okay, let's move to assessment. What does a good initial assessment cover in home health?
It needs to be comprehensive. Looking at the physical, psychological, social, and economic factors, you need the whole picture to tailor the care properly.
The whole person, not just the diagnosis.
Right. Identify the specific needs, do it in a timely way, and document everything clearly in the patient's record.
Documentation is key for the whole team.
Absolutely. And there should be policies ensuring this consistent approach.
Are there specific minimums for what these assessments must include?
Yes. The service defines the minimum content based on laws, regulations, professional standards, and the scope for each discipline, nursing, therapy, etc., needs to be defined in writing.
Clear roles and responsibilities.
And only qualified, licensed individuals perform these assessments. Plus, assessments need tailoring for special populations, adapting the process for unique needs and risks.
Individualized approach. What about screening for abuse or neglect? That seems really important.
Extremely important. There must be a clear process to identify, report, and refer suspected cases, following all laws. This means defined criteria, staff training on using them, referral pathways to community agencies, and careful documentation.
A crucial safeguard. And nutritional and functional needs. Are they assessed too?
Yes, everyone gets screened for nutritional status and functional abilities initially. If the screening flags a potential issue, a more in-depth assessment follows.
So screen first, then dive deeper if needed.
Exactly. Qualified professionals develop criteria for who needs a deeper nutritional or functional assessment. Those identified get the full evaluation.
Makes sense. And pain, how's it handled?
Everyone is screened for pain.
Yeah.
If pain is present, a thorough assessment is done. This could involve referral or a comprehensive assessment by the home health service itself, looking at intensity, quality, location, frequency, duration.
Getting the details.
Using tools like the 0-10 numeric scale or the Wong-Baker-Faces scale.
The FACES scale, right, helps people describe pain.
Yes, and the recorded pain level informs treatment, follow-up, and tracking progress over time.
A systematic approach. So after the initial assessment, how is care monitored? Reassessment.
Patient needs are monitored continuously with regular reassessments at appropriate intervals. This checks their response to care and helps plan next steps, continuing, adjusting, or discharge.
Ongoing evaluation.
Yes, again, SOAP defined in writing, done by qualified people, documented clearly. Timing depends on the patient's condition, plan, and the services they get.
And what's typically covered in these reassessments?
Things like new complaints, the interventions being used, expected outcomes, how often interventions happen. The timing and focus might differ a bit between nurses and physicians, but it's all about checking progress and adjusting the plan. For instance, nursing might reassess current complaints and interventions monthly, while a physician might do a full reassessment every 6 months, or if the condition changes significantly.
A dynamic check-in process. Once you have all this assessment data, how is it actually used?
It's documented so the whole team can access it. Then, the findings from different disciplines are integrated, analyzed, and prioritized.
Integrated, so everyone sees the full picture.
Exactly. And crucially, the patient and family are involved in decision-making based on these results. Needs are prioritized with them.
Collaborative care planning. Good. What about lab and diagnostic imaging services?
For labs, there need to be clear policies for everything. Ordering, collection, identification, transport, disposal. If using outside labs, they must meet quality standards and results need to be timely. Same rigor applies if point-of-care testing is used at home.
Quality control is key. And imaging.
Access to diagnostic imaging needs to be timely, meeting patient needs. Services must comply with standards, laws, and be overseen by qualified people. Access to specialists should be available if needed.
Ensuring necessary tests happen safely and promptly. And the last bit under PAA is service user referral.
Simple but vital. Refer patients to other providers when needed to meet their needs fully. It's about comprehensive care coordination.
Connecting patients to the right resources. Okay, let's shift to patient rights and responsibilities, PRR. This feels fundamental.
Absolutely fundamental.
Okay.
The service must have processes supporting patient and family rights. Care must respect personal values, beliefs, privacy.
Dignity and respect.
Yes, and supporting their freedom, dignity, self-expression choices, protecting them from neglect, exploitation, abuse. Confidentiality is paramount.
Protecting the patient on all levels. What about information and participation?
Patients need to know how to get info about their care and costs. They have the right to be involved in the care process, understand their condition and treatments, and participate in decisions.
Empowering them as partners.
Exactly. And informing them about their right to refuse or stop treatment.
What about complaints or disagreements?
They need to know the process for handling complaints or conflicts and their right to participate. Staff need training on respecting patient rights and values.
Clear processes and trained staff.
And information about rights must be given in a language and format they understand. Informed consent is also critical.
Informed consent. Tell me more.
It's essential for treatment and research. The process must be defined, done by trained staff. Patients need enough information about their illness, treatment, and providers to make informed choices. There also needs to be a process for when someone else provides consent, respecting laws and culture.
Right, and research participation.
Patients need info on how to access research details and how participants are protected. Informed consent is required before participation, and there should be oversight, like an ethics committee, for any research involving human subjects.
Protection and oversight. Got it. Let's move to patient care and continuity of care, PCC, the actual delivery.
Okay, care delivery. Policies and procedures must ensure uniform, evidence-based, individualized care documented in the record. Needs to respect the patient's daily routine where possible while meeting health needs.
Balancing care with their normal life.
Right, and clear identification of who can write orders and where they're documented. All care provided is documented, and the plan is revised if the patient's condition changes significantly.
Consistency and adaptation. What about higher-risk patients?
Specific policies needed for high-risk patients or high-risk services. Examples include patients on complex meds, the very ill, those with communicable diseases, or those at risk of abuse. Certain conditions also demand extra focus, like seizure disorders or impaired skin integrity.
Recognizing and managing higher risks specifically. What about nutrition?
Patients and families get nutritional education based on needs. Hydration is managed. If specialized nutrition like tube feeding is needed, policies cover safe preparation and administration. At risk, patients get a nutritional plan and their response is monitored.
Addressing nutritional needs systematically. And pain management.
Pain assessment and management must meet individual needs and be part of the overall care plan. It's integral, not an afterthought.
Addressing pain proactively. What about end-of-life care?
The service must address end-of-life care to optimize comfort and dignity for the dying patient. Focus on alleviating suffering, respecting wishes.
Compassionate care at the end of life. And transferring patients.
If a transfer to another setting is needed, there must be a clear process. The receiving provider gets a written summary of the patient's condition and care provided. Transportation needs should also be considered.
Ensuring smooth handovers. Okay, next is patient medication management, PMM. Medication safety at home. Tricky.
It requires careful organization and compliance with regulations. Policies cover how patients use meds at home, sample control, safe prep, dispensing, storage.
Storage is key, especially for special med.
Definitely. Specific guidelines for chemo, hazardous drugs, emergency meds. Ensuring emergency meds are available and monitored. Managing recalls effectively. And if meds are delivered home, ensuring stability, potency, and timely delivery to the correct patient.
Lots of logistical checks. Who administers meds at home?
Often patients, family, or caregivers. The service must identify who is qualified among their staff to administer meds, if they do. If staff administer, there's a verification process against the order, and everything is documented in the patient record.
Verification and documentation.
And monitoring.
Medication effects must be monitored, including adverse effects. Errors and near misses need to be reported through a defined process to learn from them and improve safety.
Reporting and learning from errors. Okay, last patient-centered standard. Patient and family education, PFE.
Crucial. Education supports patient-family participation in decisions and care processes. Needs are assessed, documented, considering ability and willingness to learn.
Tailoring the education.
Yes. Education covers safe med and equipment use, potential interactions, nutrition, pain management, rehab, home safety, emergency planning, also handling hazardous materials or medical gases safely, if applicable. Covering all the bases for safe self-management.
And the delivery method matters. Consider values, preferences, allow interaction, use understandable language and format. All professionals involved should collaborate on education.
Coordinated, understandable education. Great. Now, let's shift gears to the management side. Home Health Department Unit Management Standards.
Right. The organizational backbone. First is improvement in quality and patient safety, IQS.
Quality improvement. What does that involve?
Leadership involvement is key. Designing effective processes, selecting and collecting data. Remember the 5 key measures for clinical, managerial, and each PSG.
Data collection is central.
Yes. Then validating and analyzing that data regularly, comparing it internally and externally against benchmarks.
Using data to drive improvement.
Exactly. Also, identifying and managing sentinel events and near misses, analyzing trends, taking action on undesirable variations, implementing proactive risk management programs to reduce risks for patients and staff.
A continuous cycle of measure, analyze, improve, and manage risk. Next is infection prevention and control, IPC, from the management view.
Need qualified individuals overseeing the IPC program. A comprehensive program based on current science and guidelines to reduce infection risks.
Risk-based and evidence-based.
Focus on high-risk procedures, implement strategies like staff immunizations, ensure barrier techniques and supplies are available and used correctly.
The flies in training.
And providing ongoing education on IPC to staff, patients, and families.
Okay. Then management and safety of the environment, MSE.
Qualified pros oversee a program for a safe environment complying with regulations. Includes planning for physical safety, managing risks in the home environment.
Managing risks in patients' homes. That's complex.
It is. Requires fire safety plans, ensuring safe utility systems, managing hazardous materials and waste properly.
What about equipment management?
If the service provides equipment, there needs to be a program for inspection, testing, maintenance, documentation, proper delivery setup, and crucially, emergency maintenance, backup systems, 24-hour support if equipment failure is a health threat.
Backup plans are essential.
And staff training on all environmental safety aspects. Fire, security, hazardous materials, emergencies, equipment operation, utilities, regular testing of their knowledge.
Comprehensive staff training. Next up, staff qualifications and education, SQE.
Leaders define required education, skills, knowledge for all staff. Clear job descriptions, processes for recruitment, evaluation, appointment, ensuring staff competence matches patient needs and job requirements, documented personnel info, reviewed staffing plan.
Getting the right people with the right skills.
Yeah.
And their development.
New staff get orientation. All staff get ongoing in-service training and education to maintain and build skills. Patient care staff need demonstrated competence in resuscitation techniques. Provide time and facilities for training, opportunities for professional growth.
Investing in staff competence.
Yes, and a staff health and safety program. For medical staff, robust credentialing, privileging based on qualifications, and ongoing performance monitoring. Similar processes for nursing and other practitioners.
Rigorous processes for all clinical staff. Okay, governance and leadership GAO. How the department is run.
Senior manager oversees operations, ensures compliance. Leaders define mission, values, plans, policies. Plan with the community, ensure needed service equipment meds are available. Accountable for contracts, ensuring independent practitioners are credentialed.
Strong, accountable leadership.
Leaders need education in quality improvement, ensure uniform recruitment retention programs, implement effective organizational structure. Directors for each service provide direction, coordinate care, recommend resources, define staff criteria, provide orientation training, evaluate service and staff performance.
Leadership at multiple levels.
And a framework for ethical management covering business practices, conflicts of interest, patient rights, promoting ethical decision-making. Finally, leaders must create and support a culture of safety throughout the department. Monitor it, take action to improve it.
Fostering that safety culture is key. Last management standard. Communication and Information Management, CIM.
Facilitating effective communication with the community, patients, families, and among professionals internally and externally. Leadership plans for this, ensuring proper management of patient records, confidentiality, security,
protecting information,
and using aggregate data collected information for analysis and improvement, using information strategically.
So connecting people and using data wisely.
That sums it up well.
Wow. Okay, so as we've heard, ensuring quality in home healthcare is, well, it's a really comprehensive and multifaceted effort. It's guided by this whole set of detailed standards.
And they're not just rules on paper. They're actively in place to protect patients and ensure they receive the best possible care right there in their own homes.
We've definitely covered a lot today. Everything from patient safety goals and those detailed assessment processes
to medication management, the qualifications of the professionals involved.
Right. Each one of these pieces plays a vital role in building what should be a reliable, high-quality home healthcare experience.
We really hope this look into the standards has provided some valuable insights into what underpins the quality of care you should expect.
Yeah, because understanding these principles really empowers you, the patient or family member, to be a much more informed participant in your own health journey.
Absolutely. And for anyone wanting more detail on any specific area, please do check out the source document linked in the description.
And remember to visit Tary.care to learn more about how Tary, as a medical health tech company, is committed to advancing quality in healthcare.
So maybe a final thought to leave folks with.
According.
As technology keeps evolving, wearables, telehealth, AI, how might these standards we've discussed need to adapt?
That's a great question. How do we maintain safety and effectiveness while embracing innovation in home health?
It's definitely something to think about as the future of healthcare unfolds right in front of us.
It really is. A question worth pondering. Thank you so much for joining us on the Tary Podcast.